Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hello and welcome back to another installment of the Fuller Butz podcast, a behind-the-scenes look at plastic surgery. I'm one of your hosts, Dr. Sam Fuller, and joining me again is my co-host, Dr. Dan Butz. How are you doing?
I'm good. How have you been? Busy week?
Busy. Yeah, I was just thinking, is your last name supposed to be pronounced Butz or Boots, or is it actually Butz?
That's what you were thinking right now?
Well, as soon as I said, I was like, are we really the Fuller Butz podcast, or what are we?
Yeah, technically it's supposed to be Butz, but we gave that up generations ago.
Okay, well, Fuller Butz is trendier. I think we'll keep it at that.
Yeah.
Yeah, how's your week going?
Good. Just, getting busy fall Q4. Excited to be back here and chatting with one of our old colleagues.
Yeah, we are very excited to welcome one of our esteemed colleagues, Dr. Deana Shenaq from Rush University. Deana is an extraordinary microsurgeon, breast reconstruction specialist, but really does lots of things in the general world of plastic surgery. She originally hails from Texas and attended the University of Chicago for medical school, where she won numerous awards, including the Gold Humanism Award, which means that she is the best human in the world, and ended up doing research, staying on, and completing her full plastic and reconstructive surgery residency at the University of Chicago, just a couple of years behind Dan and myself. She went on to complete a prestigious microsurgery fellowship in New York at Memorial Sloan Kettering, and then returned back to Chicago, where she enjoys spending some of her free time on the waterfront and biking and so forth that hopefully we can get into today. But she's now the program director at Rush University. She's assistant professor. She enjoys teaching, training, operating, all of the things that makes a successful plastic surgeon. And we are very excited to pick her brain today on our podcast. Deana, how are you doing?
Thank you, Sam. It's so nice to be here. I really appreciate y'all inviting me, and it's great to catch up with both of you. Thanks so much for having me. How have you guys been?
Yeah, so it's been good. Just talking on podcasts all the time and occasionally playing some video games. But yeah, staying busy.
Good.
Sam kind of dove into your training there, and all the hats you're wearing. Tell us a little bit about kind of what your current role is. What does a program director do? What's your kind of day-to-day life look like at Rush?
Yeah. So this is my 7th year at Rush. I love working. Seventh year, crazy.
Wow.
But it's the same job I had right out of fellowship, right out of training. And I do wear a lot of hats. Part of my sort of academic hat is to be in charge of the training of our residents. So we have 13 plastic surgery residents, and we take residents in an integrated program, meaning that we take them directly out of medical school and train them for 6 to 7 years to be a competent, safe, compassionate plastic surgeon. And I am in charge of their overall education and professional development. And it is one of the most fun experiences I've had, but also the most humbling. And I think that we have great residents, and I feel lucky to be in this role. So that is one of the hats that I play at Rush.
So as program director, do you feel like it's still hard to get into plastic surgery? Do you have any numbers from the rank or the matching as far as like how many people are applying for those spots? Dan and I are out of the loop. We're in private practice, but maybe just to give some of our listeners an idea of how many people are vying for these few coveted spots.
Yeah, so I can tell you a little bit about sort of we're in the midst of application season now, and plastic surgery is a very highly competitive specialty. I think when we were applying, there were around 80 or 90 plastic surgery programs. There are much more, I think over 100 integrated programs now. But for this year's match, we had over 350 applications for 2 spots each year. So it is pretty competitive, and all of the applications that we've received are very stellar. So it's really hard nowadays to make yourself stand out. Everyone has great scores, great publications. So we're really looking for the right fit with our plastic surgery family.
And just to follow up on that, has AI or ChatGPT or any sort of new technology either changed how residency training is or how residency applications are? This is just, totally off the cuff, just out of curiosity, just because we're so far removed from that. But I know that in lots of different fields and realms, like even I'm looking at some college lecture halls, and they just press record on their laptop and it like makes notes for them and things. Is that happening in medicine too?
Yeah, that's crazy. So it's funny that you asked that. So I think that there were some issues even with in-service preparation, because people were using AI to sort of generate in-service questions. And if you remember that, the in-service for all the listeners is, a test that each resident takes each year, and it's part of our board certification. And so I know that people were using AI to generate these questions, and it's almost too true to the real test. So they actually took down sort of the practice test that we all were used to using online. So it's definitely being used in education. And I don't know if Dan, do you remember that GoPro project that we did?
Yeah.
As residents? I show that to everyone. Your video with how you were like testing and stuff, because I have started making my residents wear a GoPro in the OR so we could kind of review their skills and their techniques and their efficiency. So that's an old technology, but
yeah, we were way ahead of the curve. I know it's been 10 years ago. That's wild. They've gotten so much better now. So you've been in Chicago for a long time. I mean, you obviously left for a couple of years or so to New York, from being from Texas. Like, what do you love about Chicago, the Midwest, that drew you back to kind of settle down here for good?
Yeah, I mean, I enjoy living in Chicago. I'm a true Texan at heart. I love the South. But I really came back because I thought Rush was an awesome job. It was a great place to work. It was great, to come to a place where they just were like, we want you to help start a microsurgery program here. And I think for someone that is straight out of fellowship, it was an awesome opportunity. And then also my husband, he is from Ohio, never wants to move to Texas, and Chicago is what we settled on and compromised. And so
he would get so sunburnt down there.
Well, I made the mistake of bringing him down there in August. He was heating up like that red hair was not agreeing with him with the Texas heat. But if it were up to him, we would live in Cleveland. But Chicago is a great city. Love the outdoors. I like it in the summertime. It is like 70 degrees right now, so it's pretty nice. But the winters get pretty cold.
Remarkably mild, yeah.
Yeah.
So you mentioned that you were brought there to start a microsurgery program. Like, what does that mean? Like, can you take our listeners through how that goes from technology and microscopes to pre-op and post-op training, education for nursing staff, and if there's any gadgets or gizmos to help microsurgeons kind of monitor their flaps and their free tissue transfers remotely and things, just to kind of clue us in on what it takes, because you can't just show up at a hospital and say, oh, I'm going to start doing microsurgery. There's a lot of teamwork that's involved.
Yeah, so microsurgery is definitely a team sport. And I think As you mentioned, there is a lot of legwork that goes into developing a program. And I think that's something that we don't always get to see as residents in our training. We don't always see the behind the scenes. And so, Rush is an awesome place for microsurgery. So microsurgery, is basically doing operations under the microscope, transferring tissue from one part of the body to another, and letting it live on its own blood supply. So in order to do that, you need a microscope, and that costs money. You need special instruments, which also costs money. And then you need a team that's familiar. The cases are long, and so you need a team that is kind of with you to the end. And we have an awesome team. As I mentioned, the cases are complex, and it's nice to have people in the operating room that you can rely on and, that motivate you. And when, it's 6:00 and something may not be working correctly, and, they're like, you can do it. It's great. So we have a great team. But also a lot of it is post-op care, and the flaps within the first 24 hours is most critical. So we train our nurses to check the heartbeat of the flap, just like we would check a baby's heartbeat with a Doppler machine. And there's a lot of training that goes into that. That's all part of building a program, and then also teaching the residents how to monitor the flaps so that they can see patients and round on them and things like that.
So back in the day, when Dan and I were in training doing microsurgery, these could be 8-hour, 12-hour cases. And especially we're going to get into breast reconstruction, pretty soon here to get to some of the finer details for that. But these breast reconstructions where we're using like abdominal tissue to reconstruct the breast afterwards, they'd be in the hospital for several days. Is that still true? Are these still 10 or 12-hour surgeries and multiple days in the hospitals? Or there are rumors, and we had a previous guest said that there's some trends for faster or even outpatient type of microsurgery options. So maybe provide our listeners and individuals who are interested in this topic some insight on what a microsurgeon tells patients about what their microsurgery hospitalization is like.
Yeah, so I think that the trend is to do surgeries faster and more efficiently. And I think we're able to do that because we have these specialized teams now. I also have a wonderful partner that I do my microsurgical cases with. We both did our fellowships at Sloan Kettering, so we kind of operate the same way. We're both OCD. We both, have a similar approach to patient care and are very meticulous. And I think it really helps when you have a partner that you can rely on, and that makes the operation twice as fast. I don't think we had that when we were residents. There wasn't really this co-surgeon model. And I think it really helps because at the end of the day, microsurgery can be a very, non-exhausting procedure. Most of the time, I'm home in time for dinner. It's, at least for breast reconstruction, very, very reliable. Knock on wood. I don't want to jinx ourselves, but we have very good reliability rates. And, in residency, there were a lot of takebacks and, issues and things like that. We don't see that as much anymore. And then I think the trend is to get patients out of bed earlier and move them out of the hospital so that they're only staying a couple of nights. There are centers that have moved to outpatient deep flaps. And I think that that's awesome. We have not. I'm still a little bit conservative. And so we haven't moved quite in that direction at Rush, but definitely have less of a hospital stay than we did, when we were training, 7-8 years ago.
Yes, wild. Outpatient deep flaps just sounds aggressive. And I've heard even some people are doing this as a cosmetic surgery to basically do a mommy makeover without implants, but doing flaps instead of, which is crazy.
We now do contralateral augs with deep flaps. So if a woman wants it for their cancer side, but they want to be a little bit bigger in size, and so what we do is we'll do a deep flap for their cancer side and then take a smaller flap for the opposite breast to augment that. And so whereas previously we would have put an implant or done liposuction and fat grafting. So that's something new that we are doing, but there are definitely people around the country that are doing it for mommy makeovers. And I think, that's great too. Having an option to have your own tissue without worrying about an implant is a great option for patients.
So let's kind of take a step back to like breast reconstruction options. Like when you see a patient, like what's your kind of discussion about, if they have breast cancer on one side and, maybe they won't considering doing the other, different reconstructive options, no implants, autologous tissue. Maybe just kind of give us a little synopsis of how you present that and some of the pros and cons.
Yeah, so I think breast reconstruction is such a personal choice. So I really believe in sort of educating patients about what their options are and ultimately helping to guide them to the best decision. I don't want to make a decision for a patient. And I think it depends on a lot of different factors. So, first we start with what is your cancer plan? What is your cancer treatment going to look like? Do you have cancer on one side or both sides? And if it's just one side, are you considering a prophylactic procedure or mastectomy on the opposite side? And there are a lot of factors that come into play for that, whether a woman's going to do one side or two sides. Some of it is genetic factors. So if they've been diagnosed with a genetic mutation, they may choose to have a prophylactic mastectomy on the opposite side. So it all starts with that. And then preservation of the nipple. Are they a candidate for a nipple-sparing mastectomy? Because that may dictate a lot of the timing of our options. And then we talk about, the pros and cons of implants versus flaps. Just in general, I tell patients that, there are two main options for breast reconstruction, using tissue expanders or prosthetic devices or using their own tissue. And when we say the own tissue, that can come from multiple parts of the body, most of the time from the abdomen, although I do a fair amount of flaps from the inner thighs for women who may have already had a tummy tuck or they may not have enough abdominal tissue to make a breast.
So what's the breakdown, and we're not going to hold you to this, but as far as, patients who come in who opt for implant-based reconstruction, so, maybe a percent of like who are going to get tissue expanders, patients who are going to get direct to implant, and then you're going to use, the third option is autologous. So taking tissue from their belly, their thigh, different areas of their own tissue. What's the breakdown in your practice between those three groups?
Yeah, so I think my practice is a little bit skewed as a microsurgeon. So, I'm doing about 2 flaps a week. And then the other 2 days I do about alloplastic or implant-based breast reconstruction. So it's really 50-50 in my practice. So I see a high volume of microsurgical patients, but that probably is not representative of the trend in the United States. Breast reconstruction with implants or expanders is definitely more common than microsurgery. But I would say microsurgery and using your own tissue is becoming more and more popular as many women are choosing to forego implants.
Whenever I see these patients in the office, I feel like they're so overwhelmed. Like there's just so much information. They're being paraded from medical oncology to radiation oncology to general surgeon to plastic surgeon. Do you have any tips or tricks on how to calm them or simplify this? Because, we're talking about, well, we can, dissect and remove your gracilis muscle from your thigh and we can put it back in your breast. Like to me, like that's just something that would be a lot to take in. So do you use like pictures, illustrations? Like, do you have a video, or do you just really try to get to the bare bones of like or do you have more than one visit? Like, how do you try to simplify it? Because I feel so bad for a lot of these women who come in because they're just shell shocked. They're just trying to make sense of something that, weeks ago, they had no problems with their breasts, and now they're being told that they need to be removed, et cetera.
Yeah, you're totally right, Sam. Like that first visit that you have with someone who's recently been diagnosed, it's a roller coaster for them. And, even for me, it takes an emotional toll on me too. I see young patients, some in their late 20s, in their early 30s, and you're, sometimes 6 or 7 new cancers a clinic. And, I feel for them. Sometimes I'm holding back tears, and I think, it's important to listen and be patient. But I definitely have more than one visit with patients. I think it's too much to cover in one visit that's supposed to be scheduled for 40 minutes with me. So I show pictures from previous talks. I try to show diagrams and try to really get at the root of what a patient wants, what their goal is, if there's something they want to change about their breasts, and realistically, can we meet that expectation? But I also think it's important for patients to be well informed, to do their research. There's a lot of different support groups online, but there are great resources on the American Society of Plastic Surgeons website, cancer.org. So there's a lot of good places that patients can get information on too, so they can come also prepared with questions for their plastic surgeon at the visit.
Does your tumor board cancer center have like patient advocates or nurse navigators? I mean, one thing when I was doing reconstruction for my first 3 to 5 years, there was a nurse navigator that could basically help a patient navigate all these different providers and provide some background information going in, so it wasn't totally a blank slate, which I found to be really helpful for them during kind of that overwhelming experience.
Yeah, so we have 2 amazing nurse navigators that are awesome, and they work with our patients. They know about reconstruction intimately, and so they kind of give them an introduction to options and give them the basic sort of implants versus flaps. This is what you may want to think about. And they're in clinic with our breast surgeons, so they have an idea of what the oncologic plan will be. So that's very helpful to sort of set the stage so you can have the most efficient visit possible. I think something that's also changed a lot, which I wasn't exposed to a lot as a resident, but it's MyChart. Like basically you can send your surgeon a text message, and we use it a ton at Rush, and I use it a lot in my practice. And I'm in the OR most days a week. So if a patient has a follow-up question and, my nurse can answer it right away, she'll answer it, right there on the spot. But if she doesn't know the answer, she'll forward it to me, and then I answer it when I get out of the operating room. And obviously, I like talking on the phone or talking in person with patients, but this is also, MyChart's a great way for patients to kind of recoup their thoughts and put it down on paper and just send a message directly to their surgeon and feel like they have that access to care, which I think is so important.
When I was reviewing your profile at Rush and looking at all your awards and publications and so forth, there was about 2,500 different plastic surgery procedures that was listed that you perform. So it sounds like you're doing a little bit more than breast there. Can you take our listeners through kind of the scope of your practice? I always find it interesting to see what people do.
I'll tell you a little secret, Sam. So when you first start your practice, as you know, you click everything on the box that you do every single procedure. And I actually spent my first 3 years doing all the orthopedic reconstruction for big cancer surgeries in the lower extremity. And it was fun and it was amazing, but I've always wanted to work with women with breast cancer and do breast reconstruction. So my practice in the last 4 years has really transitioned exclusively to that. But I do do about 1 to 2 days a month of aesthetic surgery, breast and body, mainly for my breast cancer patients. But yeah, so that is part of my practice. And then a lot of revision breast reconstruction, revision of implants, and even revision breast augmentation.
What was your draw or lure to breast cancer patients? Like, do you have a personal story, or is it just something that fascinates you? Is it like do you have a favorite surgery within breast reconstruction? Like, take us through what really drives your passion in that specific field.
Yeah. So when I was 16, my mom was diagnosed with breast cancer, and it was very early stage, 0 DCIS breast cancer. And I remember I found out like the day before I had to take the SAT. And I think, and she was a physician, and I saw how much of a toll it took on her to have a very early stage cancer. And even as a physician, feel like she wasn't very informed about her options. And my dad was a plastic surgeon. So even though he was a hand surgeon, like she should have been one of the most well-informed people. And so that really kind of stuck with me. And I think as I learned more and more about the field, it's very technically challenging, but also very satisfying to have, make patients feel whole again, because you see them at one of the worst parts of their life. And then I always tell them, I'm like, hey, this is very curable. Your cancer is very treatable. And a year from now, you and I are going to be laughing, and we're going to be having fun at, our 1 year visit. And so for me, it's very satisfying, and it really sort of blends, I think, the artistic nature of plastic surgery with a very technical procedure. And, I love microsurgery. I could do microsurgery all day, every day. So that's one of my favorite, procedures is the DIEP flap. And also I love doing direct to implant breast reconstruction. I think, being able to put an implant in and having a patient just be done with their reconstruction, done with their cancer treatment, and just, we call it breast in a day. I think that is, one of the awesome advancements that we have now in breast reconstruction.
So when I did a lot of direct to implant when I was doing it as well, and found them to be, patients were very happy to kind of have a relatively simple upfront surgery. But tell us a little bit about what to expect in terms of potential revisions down the line, like how many fat grafting, or whether with DIEP flap, if you're modifying that in some way, what that kind of can look like and timing wise.
Yeah, so I think so for DIEP flap breast reconstruction, I counsel patients that the first surgery is really to create the breast mound and bring the flap and transfer the tissue safely. And then, obviously we want it to look as nice as possible in one stage, but we 90% of the time do a revision procedure. And typically that's 3 to 6 months after the first surgery. And that involves achieving better symmetry, increasing or decreasing volume. So last Friday, I had a patient, she had a nipple sparing mastectomy with implants by another surgeon. She developed capsular contracture with her implants and wanted to switch to autologous reconstruction. We transferred her flap after and kept her nipples, but she felt like she was too big for the size that she wanted to be. So we ended up doing a breast reduction, moving her nipple up and lifting it after a DIEP flap. So that's another type of revision that we can do. We can make the breast smaller or larger with fat grafting. And then if you didn't have a nipple sparing mastectomy, the third and final stage is kind of creating the nipple. And there's a lot of different options for that. Patients can choose if they want it created surgically so that they can have projection, or we can refer them to one of the tattoo artists that we work with to create a 3D tattoo to make the nipples. So I do tell patients that breast reconstruction surgery in general is formed by stages, but there are some patients that are very happy after one stage, especially when we're doing it at the time of the mastectomy and in an immediate fashion, and they may not require a revision, but the majority of patients would like a symmetry procedure.
You remember my most cited paper, the C to Y Butz flap?
Oh yeah. You want to know what? I quote that paper to my residents. I make them read it. I also make them read your paper on the revolve and hooking it up to a Y connector. And they think it's the revolve is the Y connector is the coolest thing. It's caught on with all the plastic surgeons at Rush. And we all request a Y connector. And I quote Dr. Butz. Or Boots.
When I was on the gold service, Dave Song just would tell me every single day how I'm going to regret not being on his nipple reconstruction paper and how it is going to be the biggest thing. And that, Sam, you really missed out on this huge opportunity. And I guess he was right.
I had not
Right.
able to make that technique work. I don't know what type
No.
of like
I love that one.
juju you were doing in the OR. I still have to cut out the dog ear. It doesn't work for me. But yeah, I do tell my residents, you should look up
It's a
this
triple
paper.
stitch, right? It's a triple stitch.
Triple stitch.
Yeah.
There was a video involved.
So
Maybe a GoPro.
you know, right at the end of our residency, there was a trend for creating sensate flaps and like, reconnecting nerves and stuff. Is that still a thing? Are you offering that? What's the success rate? Patients who want to have sensation on their breasts following a full mastectomy, what are you telling them?
Yeah, so I think that's a great advancement that we've made in microsurgery. So, the goal should be for every reconstruction to be sensate. And I think it's important not just to have sort of erogenous sensation, but it's also protective. We have many women who don't, when they're cooking and they burn their breasts and they don't even realize it. That, we've had a whole slew of that, unfortunately, happen recently. So we do offer patients nerve reconstruction. I think that towards the end of residency, we were offering it to patients mainly who were having flap-based reconstructions, because we were taking a nerve from the flap and connecting it to one of the severed nerves during the mastectomy, or one of the intercostal nerves that we found when we were preparing the vessels to receive the flap. We now have moved towards even offering resensation to women who are having implant-based breast reconstruction. So basically, in a patient who's having a nipple-sparing mastectomy, we will locate one of the nerves that is cut from the mastectomy, and we'll take a nerve graft off the shelf. So it's a nerve that comes from a cadaver, and then connect it to a nerve to the nipple. And the outcome really depends on different factors, but I have had really good results in patients, in smaller breasted patients, because we don't have to use as long of a nerve graft. So we know that nerves grow 1 millimeter a day. So the longer the nerve graft we have to use, the longer the signal has to travel to the nerve to the nipple. So if we are putting in a large implant, we have to use a very large nerve graft. So in a smaller direct to implant patient, I have very good results with it.
Are you guys using an inframammary fold approach to this and sewing underneath that, or how are you sewing that nerve to the nipple?
Yeah, so I love an inframammary approach to nipple sparing mastectomy, because the scar is hidden and concealed. And I very rarely do any other approach, even if they have some preoperative ptosis or hang to the breast. We make it work. And I think that gives probably the best cosmetic result in my hands and my breast surgeon's hands. What I typically do is sew the nerve graft to one of the intercostal nerves laterally that is cut by the mastectomy. And then I put the implant in. And sew in sort of some type of mesh around the implant to hold it in its place. And then I have my assistant evert the skin so that I can find the nerve to the nipple. We measured the nerve graft to make sure that it's as short as possible, and then sew that with tiny sutures with loops, and put some Tecile or fibrin glue on the coaptation sites where we connected them, so that the connections stick, and then do the closure. So that's sort of the technique that I've been using.
That's pretty awesome. And I think, sometimes you can get really great aesthetic outcomes, but they're still, not sensate. So it's still, not quite a true full reconstruction. So having that option that's a great, advancement for reconstruction for sure. So, want to kind of switch the topic a little bit into, some more serious stuff from residency, but we really wanted to know who your favorite senior resident was.
Trying to think. Matt Greaves. Of course, Dan and Sam.
You couldn't tell us apart. Just
yeah.
equally confused.
No, I mean, I feel like you guys both taught me a lot. Sam was a black cloud, and he taught
You guys
me.
got along in that sense.
Yeah, I mean, he taught me that when you think you're done for the weekend after like 5 replants, there's always going to be a 6th. And Dan was a white cloud, and he taught me that there is hope. There is a light at the end of the tunnel. We all wanted to be like Dan. But yeah, no, I think about our residents. I don't know about you guys, but I have such fond memories of our residency, and it was like such a fun time in life. I think, even though it was hard work, I think we all had a fun time and got along and enjoyed it.
Thinking back to what you're saying, trying to find residents that fit the culture. I mean, having a good culture where people get along, and again, it is hard work, but you want the OR to be a happy and fun place. Is going to be humbling and trialing times throughout it, but you want to have people that are going to support you, and you can have a good time in the hospital when you're working, and outside of it, and just good memories.
For sure. I mean, I always tell our prospective applicants and even our residents, like residency, like 6-7 years of your life in your 30s, like that's a long period, and there's a lot that's going to happen. And you want to be around people that are going to support you and get you through not just your training, but through life, because things happen, and it's good to be able to have friends and colleagues that you can rely on for support. So
yeah, it's life changing. It changes you and who you are as a person and how you develop, and you hope that you find that positive culture, that place where you fit in. I think top to bottom, our residency was, we were at a very strong point where we had great faculty and great co-residents nearby us in years who helped us, and I feel like everyone had a good sense of humor getting through tough times. I will say I just took 7 days in a row on call, and Sunday night at 1:00 in the morning, I just had a multi-trauma gunshot wound to the hand that they called me about. And I'm like, I have like 4 hours left after 7 days. Like, I can't believe this is still happening to me.
So you're still a black cloud, Sam.
Yeah, it hasn't gone away, but I've embraced it ever since we had sternal wounds that were bleeding on the floor and other things that we had to pressure sores and things that we had to deal with. So
maybe we should explain what a black cloud is.
Yeah. A black cloud is like someone that is very unlucky, but actually I tell my residents that they're actually lucky because it makes them a better surgeon. But basically someone who, whenever they're on call, if something's going to go wrong, it's going to go wrong when that person is on call. So when Sam Fuller was on call, you did not want to be a patient in the hospital.
My first call in fellowship at the Curtis National Hand Center, the flap from the previous fellows went down, and I had to take it back. And I was like to the attendings, I'm like, I got this. I'm pretty good at this. So it never really, and then my co-fellows came in the next day. We're like, oh man, we wanted to do that. I'm like, we can switch calls if you want, whenever you want, because it's fine. But do you find yourself relying more on your fellowship training for your practice and your approach? Is it a combination of residency and fellowship? Like, where do you really draw on for how you approach your practice, how you teach, how you perform microsurgery?
Yeah, I mean, I'm so grateful for my training both at University of Chicago and at Sloan Kettering in New York. I think that I draw on both of it. If you guys remember, we really learned how to think about like problems, I think, at University of Chicago. Like Gottlieb and, Song, everyone was so good at teaching us how to think and solve problems and the principles of plastic surgery. And I feel like that inherently is what you need because we're the surgeon, even though, I do breast reconstruction now, I still feel like you can solve other issues in plastic surgery. But I think, Sloan Kettering taught me how to be very efficient in microsurgery, how to do it, and be home by dinner, but also do it well. And I remember my mentor, one of them, Babak Marara, who's the chair there now, telling me, like, you want your microsurgery to work 99% of the time, not 95% of the time, 99% of the time, because you don't want to be in the middle of the night going back to the operating room for a problem. And I think I learned a lot there. And I also learned, how to focus on the aesthetic result, because right now it's, we spend a lot of time training on how to technically do the operation. But at the end of the day, what the patient is going to see is how the breast looks. And so I think that is, something that I picked up from a lot of the attendings at Sloan. This cosmetic standard for breast reconstruction is so high right now. And that's not something that I think I really picked up on as a resident, but really learned how to refine in my fellowship.
Yeah, those core principles of plastic surgery and kind of problem solving, I think, is really what I reflect back on. I do very little of what I feel like I did in residency. Drainless abdominoplasties, obviously a lot of augmentations when I was doing direct implants. I think I saw one of those in residency, but
Right.
knew how to problem solve and take certain skills and translate to others, which it's just that underlining kind of knowledge base that's really the most important thing.
Yeah, agree totally. I mean, we had great training. Like, we had great mentors. Even learning, I felt like we learned from you guys and our senior residents too. I don't know, it was such a good time in life. I really enjoyed it.
Yeah, I feel like I was maybe not as upbeat and excited at the time, but reflecting back, I do have positive memories, and I do think back to Michael Howard. What can I do?
What should I do?
What should I do? And what is the problem? And like those sorts of things, and thinking back about just just legit wounds, like they're everywhere in the office, and I have partners, I have people in the community just texting me, be like, hey, what should I do here? And whether it is still Sylvadine or whether it's wet to dry or whatever, whatever it may be, I do feel like the core principles, you can address that to almost any situation. And that allows us to, to be novel and to advance and to stay with the times, because we can approach things based on principles and problem solving rather than, but I learned how to do it this way, as opposed to this is why we're doing things that way. We've been asking some of our guests how they stay stress-free, partially for selfishness, because I'm trying to find ways that I can stay calm and stress-free. But do you have ways that you, after a hard microsurgery day or radiated tissue, your eyes are burning and you just went through maybe rush hour traffic or something, like how do you calm down? What do you tell your residents are ways to calm down? What are ways that you kind of keep your balance in life and mentally, emotionally, that sort of thing?
Yeah, I think that's such a good question, Sam. I don't know. I think a variety of ways. For me, when I don't every morning, and I know it sounds crazy and like it's adding stress to your life, but it isn't. I'm like, I just need like 20 to 30 minutes of me time. Because when I get out of a case, I'm answering emails and making sure the residents are okay and making sure, what's conference the next day and things like that. So I just like from 5 a.m. to 5:25 in the morning, just stress-free. I get on my Peloton tread and I put on YouTube, and I like interior design, and I put on like YouTube home tours, and I run with the music very loud on my treadmill for 25 minutes in the morning. And I feel like people are like, how can you work out before the OR and run? And it's really not for like fitness. Like, I'm probably running at like a 5.0. It's not like that fast. But it just helps me stay calm and get ready for the day. And on the days that I decide to sleep in and skip it, I'm not the same person. And so I think some type of physical activity is good. And, my husband, who's also in medicine, is a very relaxed, chill person. And I think he is the opposite of me. And I credit him. He keeps me sane. And he, is always chasing me around with chamomile tea at the end of the night to wind down. And at first I poo-pooed it, but it really does work. So, those are just kind of two small things, but it's hard to turn your brain off at the end of the day, and I think we all are dedicated to our patients and our commitments and our family. And I think just taking maybe 20 minutes to yourself has helped me. I don't know. What do you guys do? I want to hear.
We do podcasts. I run.
Fun to hang out with each other each week, right?
Yeah, it is fun. I had 9 cases today at 2 different hospitals. So did like mommy makeover, and then distal radius fracture, skin cancer of the face, ganglion cyst excision, bilateral endoscopic carpal tunnel release, collateral ligament repair. Went to the hospital, did more cases, and I just texted my wife on the way home and been like, I just need to go for a run. I just need to like just go and just run a little bit. And so running to me is kind of like, what do you do? I'm not a morning person. I cannot do that, but if I can sneak in, especially while the weather permits, to go for a 25-30 minute run outside, even though I just had that day and, was basically, I had 2 rooms, which was really nice, which allowed me to do that. But I feel like that's the last thing your body should do. It's actually the right thing, because I feel like it just balanced me out. Was listening to some music and just kind of forget about things, days off, look at, just nature and, rolling hills and things like that I have out here, which is really nice. Dan, what are some ways that you help be stress-free?
Yeah, you might love this, Deana. I've gotten into woodworking as my mindless hobby. So I frequently.
Oh no, that was Lee.
I know you don't like that. I still have all my fingers.
That's dangerous.
Yeah, frequently,
if
I finish early in the OR. What's that?
Isn't that dangerous for your hands?
Yeah, absolutely. But yeah, if I finish early, I always like buzz out to I have this little a workshop in a garage and just kind of mess around for a few hours, build all sorts of weird stuff.
What have you built so far?
What?
You have saw stop, don't you? Don't you have a good saw?
I do have a saw stop. So I have a saw that if my fingers were to touch it, the blade kind of retracts. I built lots of stuff, little shelves. I built a bed for one of my kids recently, a desk,
wow,
picture frames.
Bunk beds, right? Pizza oven, bunk beds.
Well, bunk beds weren't really. That was more construction lumber.
Oh,
I've been like,
sorry,
all walnut, black walnut.
That's awesome. See, Sam and I are such a black cloud that we would have a mishap with that saw. Only the white cloud, Dan Butz, can get away with that.
I run with knee pads and wrist guards on.
Yes, it's been great. And the last kind of question we like to ask you, in terms of, obviously a lot has changed in 10 years. We've kind of talked about, advancements and efficiency and shorter hospital stays, and, high success rates, 99%. What do you see kind of the next 10 years looking like for microsurgery, breast reconstruction? I'd say, sensate flaps is amazing, but kind of what's next, do you think?
Yeah, I think we didn't really get into the topic, but a lot of my practice too is focusing on preventing lymphedema or swelling in the limb. And so, it's becoming more and more standard practice to do what we call lymphatic reconstruction or reconnecting lymphatics to nearby veins at the time of the lymph node removal to try to prevent swelling in the arm for patients. So I think that's something that, we're doing it as a treatment in residency, but we weren't doing it as prevention. And so, pretty much that's standard of care at our hospital now. I think the full gamut of microsurgery is changing. So we, and as residents, focused a lot on using abdominal tissue and sometimes as an alternative option in microsurgery using buttock tissue. But now we know we can make really nice flaps from the inner thighs as well. And some patients prefer that donor site. So that's other technologies that are moving in addition to sensate flaps. And then, a lot of people are experimenting with robotics in microsurgery. One of my partners is doing robotic assisted deep flaps. And so he's making very tiny fascial incisions to try to decrease postoperative pain. So I really see microsurgery moving in that direction. Microsurgery is hard on your body. So we're always thinking of ways to prevent the neck pain, the back pain. And so, there are robots that are helping with anastomoses. I haven't gotten into that yet, but there are different types of ergonomic microscopes as well. So, those are all sort of upcoming trends in microsurgery and maybe 10 years from now, they'll be standard.
Well, this has been a phenomenal podcast. We are very gracious, humbled, honored to have Dr. Deana Shenaq, not only the program director at Rush University, plastic and reconstructive surgery, but also wonderful microsurgeon, very passionate with her patients. I know I just sent you yet another patient last week who I recommended to you, who I'm having those conversations where, I don't want to be, just because I'm offering implant only, that's your only option, and discuss that. And if it's a viable treatment plan, want them to get to somebody who can offer the full gamut. But we're, Chicago in and of itself is very lucky to have you as a surgeon. Your residents are very lucky to have you. Dan, anything else you want to say to wrap up a wonderful talk on breast reconstruction and microsurgery?
Yeah, this was great. We need to catch up more often, not just on podcasts.
Yeah, thanks guys for having me. It was really nice to catch up with you guys, and I love your podcast. I think I'm going to be a weekly listener, and I really appreciate spending time with y'all this evening. So thanks for having me.
We appreciate y'all too.
Can't take the y'all out of me.
Can't get rid of the y'all.
All right,
good
guys.
night.
Everyone have a good rest of the day, okay? Good night.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.